for Bundelkhand region. He is, I think, the only he runs a multi-speciality hospital which is famous for gastroenterology. He is a director and consultant gastroenterologist and liver specialist of Bundelkhand Super Speciality Hospital. He is a towering personality, as we all know. He has done his DM from the famous SMS Jaipur Medical College, and he is going to apprise us about liver diseases in pregnancy. We all know liver is a medical problem, but when it occurs in pregnancy, then it is coincidental or it is aggravated in pregnancy. So he is going to tell us all about the liver diseases in pregnancy. We only know about few hyperemesis, fatty liver, HELLP syndrome, and preeclampsia, which leads to very bad fetal outcome, that is stillbirth, premature delivery, and fetal distress, and IUD also. So more you will hear from the dynamic Dr. Bundela. Please, I welcome you, sir. Please start your deliberation.
Heart rate, cardiac output, as well as decreased systemic and splenic vascular resistance. These are the basically biochemistries that is in normal pregnancy. AST/ALT, GGT, bilirubin, bile acids are normal in first, second, and third trimester normally. And in alkaline phosphatase may increase in second and third trimester. Albumin decrease in all trimester. And alpha fetoprotein increase in all trimesters. And evaluation of abnormal tests in pregnancy. Normally, if it is a cholestatic pattern, then go for the ultrasound without Doppler. And if it is a negative, then go for the drug-induced liver injury, PBC, PSC. If there is a strong suspicion of biliary disease, then go for the MRCP. And if hepatocellular pattern, then consider viral hepatitis, autoimmune hepatitis, drug-induced liver injury, NAS, Wilson, and work up accordingly. In case of, if it is a considered disease unique to pregnancy, then consider hyperemesis gravidarum, preeclampsia, HELLP, acute fatty liver used, but exposure time should be minimized. So Doppler should be minimized. And MRCP, MRI without gadolinium is preferred over the CT imaging. And gadolinium is contraindicated in the pregnancy. So contrast gadolinium should not be given in pregnancy. Abdominal CT without contrast is generally safe, but cumulative dose should be less than 50. So generally we consider CT is not safe in pregnancy, but less than 50 milligyride is safe in the pregnancy. There is insufficient data to recommend use of elastography or fibroscan during pregnancy, but European guidelines say it is safe in pregnancy. So fibroscan can be done, and breastfeeding is safe after iodinated or gradient contrast. Timing or typical time of onset of disease unique to pregnancy, basically hyperemesis gravidarum typically occurs in the first trimester, and rarely symptoms can persist throughout the pregnancy. ICP typically present after 30th week of the gestation and has been reported in first trimester also. So if pruritus in first trimester, then ICP may be considered also. Preeclampsia after 20th week of gestation, HELLP between 27 and 37 week. AFLP occurs in the third trimester and rarely postpartum. If disease is presenting in postpartum, the AFLP and HELLP should be considered, not other disease in pregnancy. Basically, viral disease can be considered. Disease unique to pregnancy and their management, basically hyperemesis gravidarum characterized by weight loss greater than or equal to 5% pre-pregnancy weight body weight, dehydration and ketonuria. Presence of biochemical abnormality is not required for the diagnosis of HG, and it typically occurs in the first trimester. For the majority of symptoms improve as gestation advances beyond the 20th week, and in around 20% symptoms persist throughout the gestation also. Many times 20% patients may present throughout the gestation. Does the presence of abnormal serial disease in women with the HG? Recommendation says serum liver tests are elevated in 40 to 50% severe cases, but in HG associated abnormality are usually mild and self-limiting. So liver tests generally does not affect the prognosis of HG. Liver biochemistry abnormality typically resolved with hydration and resolution of vomiting, and persistent considered for other liver disease. Coming to management, HG and liver, Windsor definition, it is basically symptoms onset less than 16 weeks of the gestation, nausea and vomiting, at least one of which severe enough to hamper the work of the patient, inability to eat or drink normally. And go for the AST/LT. If it is a normal and mildly elevated, then it is HG and managed on the line of the HG. If it is a markedly elevated, if SGOT-PT is I think thousands and 500, then it is not basically hyperemesis gravidarum, and other etiology of liver should be evaluated. If AST/LT is abnormal, it is not abnormal, then admit any of the following. Patient unresponsive to outpatient management. If patient not responding to oral medicine, then it should be admitted. Clinical dehydration, weight loss more than 5% of body weight, confirmed or suspected comorbidity like UTI or diabetes, comorbidity and unable to take medicines, then patient should be admitted. And in inpatient management, prescribe IV or IM antiemetic, IV fluid like RL, thiamine should be given to the patient. Otherwise, patient may develop Wernicke encephalopathy. So, thiamine should be given, TDS, and venous prophylaxis should be given, and PPI, and ultrasound scan confirmed to the gestational age and for trophoblastic disease or multiple pregnancy, because it is risk factor for the HG. And consider enteral or parenteral nutrition in case of patient is not taking orally. Antiemetic therapy, first line doxylamine and pyridoxamine 20/20 per orally at the night, because doxylamine causes sedation. So initiate at the night, increase to the additional dose 10/10 in the morning or lunchtime. Other drug may be considered like propyrazine, promethazine like phenargan, and chlorpromazine. And second line drug is metoclopramide, domperidone or nancitron. If patient is not responding all these, then prednisolone from 40 to 50 mg daily can be given. And basically corticosteroids should be reserved for cases where standard therapy has failed. When initiating this should be prescribed in addition to previous stated medicine. So previous medicine should not be stopped. In spite of all these medicine, steroids should be given if he or she is not responding. On discharge, up titrate antiemetic therapy, encourage oral nutrition, eat little, small frequent meal, often to prevent empty stomach. And basically up titration of antiemetic कैसे हम लोग करते हैं generally? Initially select first line antiemetic like doxylamine. Use combination of drugs in women who do not respond to the single antiemetic. When up titrating, add drugs as opposite to replacing them different classes of the drug, not similar classes of drug, and may have synergistic effect. And some women will require combination of 3 and more antiemetic. So antiemetic with different class should be given so that they have synergistic action, not a single class of drugs should not be given. Coming to ICP, basically intrahepatic cholestasis of pregnancy, pathology is reproductive hormone, progesterone, environmental factor like selenium deficiency, season generally occur in winters, and antibiotics, and genetic susceptibility like ABC4 or other genes. This factor, personal or family history, multiple pregnancy, carriers of hepatitis. So in patient of intrahepatic cholestasis pregnancy, hepatitis test should be done. And the presence of gallstone, of course. 80% present after 30th week of the gestation, but first trimester has been reported. Classical symptoms is generalized pruritus, most severe in palm and soles, without an accompanying rash, with typical onset in second or third trimester. Pruritus present in the second or third trimester plus bile more than 10, without any other cause of pruritus, is diagnostic for ICP. And pruritus can precede lab abnormalities. If initial testing of bile acid is normal, then repeat testing of bile acid should be done. If it is a normal, so you cannot say it is not. Generally, हम लोग सोचते हैं कि SGOT-PT तो not raised, so it is not ICP. Then it is not for the diagnosis. It is the bile acid that is required for the diagnosis. ICP is confirmed when serum liver test completely normalized after delivery. Then it is ICP. If it is elevated, then consider for the PBC or PSC or the diagnosis. Maternal complication of ICP are minimal, and serum transferases elevation do not appear to influence maternal symptoms and fetal outcomes. जनरली गायनी में बहुत कंसर्न्स रहती है, एसजीओटीपीटीज के बढ़े हुए हैं, तो इसमें कितना मैटरनल लॉस में रिस्क है, तो इट इज बेसिकली अमाइनो ट्रांसफरेज से कोई रिलेशन नहीं है इसका. Jaundice may occur in 17 to 75% of cases. Bilirubin, usually less than 5 milligram, develops 1 to 4 after onset of the pruritus. So generally pruritus के after 1 to 4 weeks jaundice develops, and jaundice is usually mild and may remain constant until the delivery, may persist until the delivery, and pruritus worsens with the onset of the jaundice, and patient skin become excoriated. Common सा क्वेश्चन ये है, women with ICP are measurement of SGP to bilirubin better test than the measurement of bile acid to identify women with the increased risk of fetal complication? No, it is a woman should be tested for the serum bile acid to identify pregnancy at risk of stillbirth or preterm birth. Women with confirmed ICP bile acid should be measured at least weekly from 32 weeks. Weekly from 32 weeks to identify those with concentration more than 40. And women with the post risk of stillbirth increases after 30 weeks of the gestation, and elective early delivery should be planned. If it is more than 100, if at the 30th week, then early delivery should be planned at the 30 week or 35 week or 36 week. Maternal complication, mild generally sleep deprivation, increased rate of cesarean section, increased rate of PPH. Fetal complication is more. Preterm birth, bile acid causes increases myomaterial sensitivity to oxytocin. That causes preterm birth. Meconium staining of amniotic fluid because of bile acid increased colonic motility of fetus. That's why more common in severe disease. And IUD, if BA is more than 40, direct toxic effect of fetal on fetal cardiomyocytes, arrhythmia, or placental vasoconstriction may occur. So possibility of sudden fetal death rarely occurs before 36 weeks. Before 36, possibility of fetal death is rare. Sometimes within hours. Rare, but sometimes within hours of normal fetal heart rate tracing. यदि आपका normal fetal heart tracing आ रही है, sudden IUD may occur. And umbilical RT Doppler test result more abnormal in these pregnancies compared to NST. So it is better to go for the umbilical RT Doppler as compared to NST. Management, fetal bile acid more than 100 are associated with increased mortality despite twice weekly antenatal testing. If you are doing Doppler twice weekly, still risk of increased mortality in case of if bile acid is more than 100. And inpatient admission and continuous fetal heart monitoring with delivery between 30 to 36 weeks. Can fetal death can be prevented? Predicted or prevented? Poor outcome cannot currently be predicted by biochemical tests. Delivery decisions should not be based on the results only. No specific method of antenatal fetal monitoring for the prediction of fetal death can be recommended. Ultrasound and cardiotocography are not reliable method for predicting fetal death. Ultrasound and cardiotocography is not reliable. And continuous fetal monitoring in labor should be offered. In labor also continuous fetal monitoring should be offered. Treatment, local therapy, steroid, calamine, aqueous cream, they are safe, but efficacy is unknown. They are safe in pregnancy, and some patients get temporary relief only. And medication like UDCA, only UDCA medicine that improve fetal outcome. Other drugs like dexamethasone, cholestyramine, SAMe, phenobarbital, all these drugs are only for the decreasing pruritus. And vitamin K decrease the risk of vitamin K basically increase the risk of abruption postpartum hemorrhage. So vitamin K should be given to the female even though patient is having normal PTINR. Guidelines, all guidelines consider UDCA as the first line of therapy recommended by the RCOG, ACG, ESL. These are the meta-analysis that showed UDCA decreased pruritus in 73 to 100%, improved liver function test in 80 to 100% of cases, cesarean section rate not significantly impacted by the UDCA, prematurity reduction yes, neonatal admission in ICU reduction is yes toward the lower side. So UDCA treatment should be recommended for women with ICP to reduce adverse maternal and fetal outcome, basically for the fetal outcome. This is basically a chart showing the management of the ICP or differentiation of the ICP with other diseases. Women present with the pruritus with or without rashes, if ICP is suspected, go for the two tests, total bile acid and AST/ALT. Group A showing if both are normal, then and patient is having pruritus, then go for the bile acid testing 2 to 3 weekly. If it is normal till the delivery. So consider delivery at the 39 of the weeks. Second group, bile acid is normal and AST/ALT is raised. Basically, these are the group like preeclampsia, AFLP or HELLP syndrome. If patient is having pruritus, then go for the liver testing and bile acid 2 to 3 weekly. And delivery, you may extend up to the 39 weeks. And group C, basically these are the ICP cases. And if bile acid is less than 40, then consider weekly bile acid LFT after 34 weeks and consider induction 39 completed weeks. If patient is having bile acid 40 to 100, then similar should be done and stop treatment UDCA at time of delivery. And 39, you can extend such kind of patient up to 39 of weeks. If it is more than 100 and more than 100 or more than 35 week of gestation, considered UDCA treatment, weekly bile acid and LFT, and recommended delivery from the 35 week of the gestation. So if it is more than 100, so go for the 35 weeks and reduce UDCA gradually over the 2 weeks post delivery if she is having more than 100 bile acid. And ensure bile acid, AST/ALT, bilirubin to return normal within 3 months of delivery. If it is not returning to the level, then primary biliary cirrhosis or PSC should be considered. Occurrence of ICP is believed to be 45 to 70%. In patient with a history of ICP, OCP contained estrogen should be used with caution and at lowest dose possible. Postnatal care, LFT should be deferred at least 10 days postnatally, as in normal pregnancy, LFT may increase after in first 10 days of the puerperia. Postnatal resolution of symptoms and biochemical abnormality is required to secure the diagnosis. These are the other diseases that is having confusion with the ICP like PVC and PSC. Hypertensive disease of pregnancy, abnormal liver associated tests in the 2nd or 3rd trimester, usually after 20th week of the gestation. All disease excluded like biliary disease, viral disease, autoimmune disease, and medication excluded. And patient is having hypertension more than 140 by 90 pp, proteinuria more than 300 mg per 24 hour. If these are present, these are the patient of the basically preeclampsia or eclampsia. And for eclampsia without severe features, delivery is recommended at 37 week. However, delivery at 34 week is recommended with preeclampsia with severe features. HELLP syndrome, abnormal liver test, all biliary disease has been excluded. CBC count showed hemolysis and thrombocytopenia. If it is a present, then it is a HELLP basically. And monitoring management of HELLP syndrome or preeclampsia with liver derangement. First is identification. BP monitoring, clinical assessment, laboratory tests like urine examination, full blood test, liver enzyme, liver function test, fetal assessment like fetal growth, Doppler studies, monitor BP, proteinuria, abdominal ultrasound, risk stratification, patient is having chest pain or dyspnea, oxygen saturation, platelet count, creatinine, AST/ALT, and stabilization. If patient is having more than 140 by 90 BP, go for the labetalol, nifedipine, and methyl-dopa. If patient is having more than 160 by 110 BP, then hospitalize that patient and antihypertensive magnesium sulfate should be given. If gestational age is less than 34 weeks, corticosteroid for lung maturity should be given. If it is less than 32 weeks, then magnesium sulfate should be given. Delivery 4 weeks, prompt delivery once maternal coagulopathy and severe hypertension have been corrected. Less than 34 weeks, first expedite delivery with optimized maternal pregnancy outcomes. Guidelines statement: HELLP syndrome or eclampsia suspected, delivery is recommended after maternal stabilization. Abdominal imaging should be performed in suspected HELLP to rule out a hepatic hemorrhage, infarct or rupture. If patient is having severe pain, go for the ultrasound to rule out the hepatic hemorrhage, infarct or rupture. HELLP syndrome complicated by the hepatic rupture or ALF should prompt transfer patient to the transplant center. Should not be kept in the hospital. Acute fatty liver pregnancy, estimated risk factor include primary birth, male infant twin pregnancy, associated between AFLP and LChat deficiency in the fetus. Basically, fetus is having LChat deficiency. If hepatic encephalopathy occurs, there should be high suspicion for the acute fatty liver pregnancy. And DIC is noted in 10% of the cases of the AFLP. These are the basically diagnostic criteria for FLP, Swansea criteria. If more than 6 of the following are present, like ascites, coagulopathy, increased ammonia level, increased AST level, increased bilirubin, increased urate, hypoglycemia, leukocytosis, microvascular steatosis and liver biopsy, polydipsia, renal impairment and vomiting, then consider AFLP. If patient is having hepatic encephalopathy, hypoglycemia, there is a high suspicion of acute fatty liver of pregnancy. Women with acute liver of pregnancy should be considered for the ICU admission. If patient is having encephalopathy, elevated lactate level more than 2.8, MELD score more than 30, score more than 7. Guidelines: AFLP suspected, delivery is recommended after maternal stabilization. Diagnosis of AFLP can be made on the clinical and laboratory parameters. And imaging should be performed in AFLP to rule out hepatic hemorrhage, and all newborns should be screened for the LCHAT deficiency. These are the HELLP and AFLP. If patient is having predominantly altered sensorium, polyuria, polydipsia, coagulopathy, acidosis, acute kidney injury, hyperbilirubinemia and hypoglycemia, these are the cases of acute fatty liver pregnancy. If patient is having basically hypertension, thrombocytopenia, then consider for the HELLP syndrome. Management of chronic liver disease during pregnancy, lactation, hepatitis B. All pregnant women should be tested for the hepatitis B. Prevention of maternal to child transmission of hepatitis B is important. Although the infant vaccine, hepatitis B immunoglobulin are highly effective in prophylaxis failure occur in the 15% of the pregnancy. 15% of pregnancy. Increased transmission with invasive procedure like amniocentesis should be discouraged. Quantification of SBB DNA in second trimester should be done. If DNA is more than 2 lakhs, antiviral therapy should be started between 28 and 32 weeks to reduce transmission. Antiviral therapy should be stopped at delivery or up to 3 months postpartum. And if antiviral is required, tenofovir 300 mg is preferred, but tenofovir alfenamide is also safe. ESL guidelines says it is safe in the pregnancy. Monitoring of ALT DNA for 6 months postpartum or after cessation of antiviral is recommended. Caesarean section is not recommended to reduce risk of SBB mother to child transmission in HBsAg positive women. Caesarean section may be recommended in only ASEAN. ESL guidelines says only in ASEAN caesarean section can be done if patient is HB antigen positive with high viral load 10 to power 7 who have not received antiviral therapy during pregnancy. If patient has not received antiviral during pregnancy, then only in ASEAN can be considered for the caesarean section. And breastfeeding of infant born to HBsAg mother should not be discouraged unless mother with detectable DNA with cracked nipple or infant has oral ulcer. If patient is having infant is having oral ulcer or there is cracked nipple and female is having detectable DNA, then breastfeeding should be. Hepatitis C management: pregnant women should be tested for SCV during each pregnancy, and those positives should be evaluated for antiviral after completion of pregnancy and breastfeeding, because direct antiviral is not safe. Preconceptional antiviral should be prioritized for the SCV infected women of childbearing age to eliminate risk of transmission during pregnancy. Therapy includes ribavirin. Highly effective contraceptive is required. Conception should be deferred for at least 6 months following last dose of ribavirin. Ribavirin is basically teratogenic, and there is insufficient data on the direct antiviral. And if there is utmost requirement, then ESL guidelines says antiviral therapy like sofosbuvir and ledesparvir has some benefit in the hepatitis C treatment during pregnancy. Breastfeeding is not contraindicated. Caesarean section should not be recommended. Hepatitis A: vaccination of pregnant women identified to be a risk of hepatitis infection during pregnancy is recommended. During pregnancy, you can give hepatitis A vaccine. Both hepatitis A vaccine, immunoglobulin for the post-exposure prophylaxis can be used in pregnancy. And hepatitis E: it is the commonest cause of acute viral hepatitis in pregnancy. Poor fetal outcomes such as preterm delivery, IUD, stillbirth are more common in pregnant women with hepatitis E other than other viruses. So it is basically fulminant in the pregnancy. Mother to child transmission of HEV can occur, especially in case of ALF. Management of ALF requires same intensive care as other cause of the ALF. In hepatitis E related ALF, little data to support termination of pregnancy to improve maternal outcome of the patient. And the decision of termination of pregnancy for improvement of fetal outcome need to be individualized by the gynecologist or multi-specialty team. Breastfeeding is considered safe in the asymptomatic patient infected with the HEB. If mother has fulminant hepatitis, then it should be discouraged. Hepatitis E vaccine recently launched should be recommended in women of childbearing age living in endemic areas, not safe in pregnancy. Hepatitis E vaccine is not safe in pregnancy, so it should be recommended in women of childbearing age. If a married couple comes to you, then recommend hepatitis vaccination to the female. And this is the first time in India, 3 doses, 0.16 doses for the pregnancy, for the female, 0.5 ml dose is there, and 100% protection after completion of 3 doses with long-term immunity of more than 80% for the 10 years. So, if a marriage couple comes to you, then hepatitis E vaccination should be given to the female counterpart. HSV, generally patient inactive hepatitis. If patient of pregnancy with thousands of SGOT-PT and not having jaundice and present in ultrasensorium, so one diagnosis should be herpes simplex virus in the mind, and acyclovir should be considered because it is safe in the pregnancy. So you can save that kind of patient also. Cirrhosis with portal hypertension, without portal hypertension in pregnancy. If a mental score is more than 10, then there is a risk of decompensation. Endoscopy, if patient is not underwent endoscopy, generally endoscopy 1 year prior to the conception should be done. If it is not there, then consider in the second trimester. And varicose screening, generally if not done in prior to conception, then in the second trimester we can go for the endoscopy. In case of varicose bleed, in physician point of view, varicose bleed, octreotide is safe, but terlipressin should not be used in pregnancy because it may induce uterine contraction, spontaneous labor, placental abruption. Next thing is, if patient is having cirrhosis, vaginal delivery is preferred. And in the presence of varices, if there is a varices, then shortened second stage / assisted second stage labor should be done. Basically, you have to reduce the timing of the second stage of the labor in case of the if patient is having a high varices. In women requiring cesarean section for the OPS indication, correct coagulopathy, thrombocytopenia, ultrasound can be used to map intra-abdominal pelvic varices. And it is important part for gynec point of view. In portal hypertension with abdominal wall varices, a median abdominal skin incision at cesarean may afford lower risk of hemorrhage as compared to the lower transverse. And for pregnant women with high-grade untreated esophageal varices, the bleeding risk may be considered very high during vaginal delivery, so warrant plan cesarean section. If there is untreated patient is having grade 3-4 varices, so normal delivery should not be tried because there is a high risk of bleeding and patient may go in the decompensation, hepatic encephalopathy, and all these things. Basically, delivery consideration for the woman with pre-existing and gestational liver disorder, only cesarean section hemorrhage precautions should be taken in case of the cirrhosis. Otherwise, delivery can be considered normal or cesarean on all case of the cases. One slide for the what should women with a liver transplant be advised regarding the risk of rejection or deterioration in the pregnancy. Female transplant recipients should be advised that delaying pregnancy for at least 1 year after the transplant. So after 1 year, she can conceive. Blood marker of rejection should be checked regularly during pregnancy, and immunosuppression titrated appropriately. Immunosuppression drug like azathioprine, cyclosporine, tacrolimus, prednisone should not be stopped. Mycophenolate mofetil is teratogenic and should be stopped. These are basically contraception in liver disease. Only combined hormonal contraceptives should not be used in the cirrhosis and should be cautiously used in the ICP and preeclampsia. Otherwise, all contraception are safe in the liver disease. Coming to MSLD, predict specific metabolic changes necessary to promote fetal growth development, including increased adipose tissue, decreased insulin sensitivity, and increased lipolysis. These changes can negatively affect intrapartum and subsequently metabolic risk for the woman with NFLD. Fatty liver and basically these are guidelines. Evaluation of symptoms associated with PCOS is recommended. Preconception counseling should include benefit of optimizing weight and metabolic comorbidity before the conception. And breastfeeding is encouraged. Basically, if patient is obese and metabolic disease, then breastfeeding is encouraged, and longer duration of lactation is associated with lower rate of future NFLD1 offspring and reduces maternal mortality, including NFLD. So, breastfeeding is beneficial for both female and child also. ELD pregnant women should be screened for alcohol use and refer for the management when appropriate. For women with ELD, counseling should include delaying of conception until abstinence is achieved. The abstinent female should be abstinence should be there for the pregnancy, and medication disulfiram should not be used. Naltrexone and acamprosate also not safe, but can be used if it is necessary. These are basically hepatic adenoma, and if it is less than 5, then follow karna hai. If it is more than 5, then it consider blend embolization or consider resection. Basically, autoimmune disease, preconception counseling should include discussion of medication safety in pregnancy, potential of disease exacerbation, drug azathioprine is safe, and mycophenolate is basically unsafe in pregnancy. So, summary: liver disease in pregnancy should be diagnosed and managed judiciously for better outcomes. It is basically should be diagnosed early, and early management of the diseases should be there. Thank you very much. Thank you.
Hope we all keep these guidelines in our practice. I would like moderators and chairpersons, if any questions, please.
More than 100, yeah, more than 40 basically. So you can generally we follow from the 32 weeks. So B low dose vitamin K B can give 2 to 3 weeks also.
How much is the dose? 5 or 10?
5 or 10.
5 or 10. Daily for?
2 to 3 weeks. You can give for that 2 to 3 weeks. Daily.
Daily.
Oral tablets are also
Oral
available.
tablets, yeah. We are asking about that is most common. The treatment is deoxycholic is very good. But what is your view on the rifampicin?
Rifampicin, ma'am, it is only reduce the cholestasis, pruritus only, but no effect on basically fetal or maternal outcome. But it is only for the pruritus. Rifampicin, dexamethasone also for the pruritus only.
I think it is very good in fatty liver. Can be given? Have you tried this?
In the pregnancy, ma'am. In the pregnancy.
Usually we don't prescribe so.
In every patient of hyperemesis in first trimester, we should go for bile acid test or liver test.
No, ma'am. If patient is not having a cholestasis pruritus, then the bile acid is not necessary for the hyperemesis remediation. And LFT, I have already shown in the slide. LFT is not necessary for the diagnosis of HG. It is basically clinical criteria for that. Biochemical criteria is not for diagnosis or confirmation of HG. It is basically symptoms, that is before the 16 week and never to take anything. That is the basically.
What can be the maximum?
Ma'am, maximum dose of ursodeoxycholic can be 2000 per day, 2000 milligram or 2 gram per day may be given.
Any questions?
General dose is 10 to 16 mg per kg body weight. Otherwise, we can use up to 2000.
Patient came with a very dark status, but ultimately it came out to be allergic reaction. There's a big differentiation.
Because basically bile acid should be done. Without bile acid, you cannot say it is ICP.
We simply diagnose this anti-pruritus without rashes is not due to pregnancy. This bile acid. If it is rashes without rashes, then if it is with rashes, it is allergic reaction most of the time.
Because rashes may be there, but without rashes, generally present without rashes. But if patient is having intractable itching, so
yes.
basically rashes of itching will be there. Otherwise, typical rashes of disease like in the viral hepatitis would not be there.
But there are so many other causes of pruritus also probably in pregnancy. And then we should always go for bile acid as you have said.
Bile acid is more than 10. It is diagnostic for the ICP.
ये साइक्लोविर आपने बोला कितने दिन तक चलेगा?
Basically 7 to 14 days you can give depending on the situation of the patient. A patient of basically large, huge increase in the LFTs and patient is having no jaundice basically, LFT is unconscious. So first should be considered in case of intracranial hepatitis, SCB infection is very common.
So maximum time of the duration for this
7 to 10 or 14 days you can give.
only.
Thank you, boss. Thank you.
And you cover all the common topics regarding pathology, pregnancy, ISDP, and health system. But I think the FELP is the very less common, but it's worse.
Less common, it should be considered deteriorating after postpartum. FLP, health syndrome, and the third is HSP. It is basically
So on this FLP, when we receive patient, most of the patients are in hepatic encephalopathy conditions in our setting. And we found that in most of the patient, the PTNR level is very raised. So, what are the options to decrease this PTNR level, and what are the treatment difference among pregnant and non-pregnant, and what are the outcome difference in this?
basically if patient is having a ALF and INR is raised, if patient not having any bleeding tendency, then vitamin K is sufficient. If patient is having bleeding tendency, then FFP should be given.
So exactly start AFP, fresh frozen plasma.
It is basically INR more than 5 or patient is having bleeding tendency, then should be advised, otherwise not.
We cannot give fresh frozen plasma
No,
without bleeding.
No.
TNR.
If there is no risk of bleeding, then should not be that. Vitamin K is sufficient.
And what are the outcome difference among these diabetic and pregnant and non-pregnant?
Outcome basically hepatitis E related fulminant in case of the pregnancy as compared to non-pregnant. So basically outcome is worse in case of hepatitis E. Otherwise all disease may present like non-pregnant females.
Good. So there is a differential diagnosis of a pregnant woman presenting with raised bilirubin. One possibility of raised bilirubin with kidney injury. So HELLP syndrome can be there, preeclampsia can be there, kidney injury. But most important diagnosis is atypical HUS. Atypical HUS is very important. So if this is missed or not given earlier treatment is dialysis. You will patient will end up into chronic kidney disease and will remain on always on dialysis. So differential diagnosis patient presenting with kidney injury with a raised on this. One is HELLP syndrome, acute fertility pregnancy, eclampsia, preeclampsia, and another is atypical HUS. So that should be considered. Thank you very much.
Thank you so much.
Thank you, Dr. Bundela, for it. I think now we gynecologists of Jhansi won't require much to send patients to you. Thank you so much. It was a wonderful
It is
session.
lost to me, but I am happy for that.
Thank you so much.
So the take-home message is, in pregnancy, if liver test is deranged, still then one gastro checkup is essential to avoid medical or any problem.
Basically, disease pertaining to each specialist should be sent to that specialist. So if patient is having AKI, it should be sent to the nephrologist. If patient is having a deranged LFT, it should be sent to the gastroenterologist. If he or she is having cardiologist, then it should be referred to the cardiologist. Basically, it is a teamwork, it's not an individual.
And if there are gallstones, we send to a surgeon. Gallstones with pregnancy, we send.
No ma'am, bile CVD stone should be sent to the gastrophysician. CVD stone is not for the surgeon, it's a modality of gastroenterologist.
Thank you very much for the very good guidance. I think we can close the session if there are no more questions, so that the next session can be started. We are well on time. Thank you very much, Dr. Bundela, once again.